Arterial, Doppler ultrasound, no pulses, IV heparin is started. So what is the most appropriate management now? Urgent left leg amputation, urgent invasive angiography, intravenous glycoprotein 2B3A, or admit and wait for watching. So he's come in, he can still move his muscles, he still can feel. Yes, urgent invasive angiography. This, remember, is equivalent to a STEMI. You need to investigate and get this open as soon as possible. So that is why B is correct. He still has strength and he's got some sensation, so you don't need to amputate the leg. Glycoprotein 2B3A have not been indicated and studied in this field. Very good. Now let's talk about the non-atherosclerotic or arteriosclerotic vascular disease. So there are two common ones. One is more common in men, young men under 40. This is Berger's disease, and AKA thromboangiitis obliterans. And you can, it's mainly in young male smokers. You can see early here, and then later you can see a complete obliteration. And this is the problem here. You can see this arteriogram. They've got a complete occlusion of those small and medium arteries distally here. You can see it's just complete cutoff here. And the main thing is here, they got to stop smoking. So just ask them, okay, here are your choices. Stop smoking, or we'll schedule your amputation. Takessu's arteritis is the commonest non-arteriosclerotic vascular disease in young under 40 women. And you can see, and the prototype here, it's particularly common in Asian women. So the prototype patient they will give you on the boards is the young Asian violin concerto player whose Shostakovich violin concerto #1 has gone to hell in a handbasket, unlike the beautiful Shostakovich violin concerto #1 that you are currently listening to. And so the etiology of Takessu's arteritis is its large vessel artery. So you can see here, here's your aorta, and you can see here these big vessels coming off the aorta, and hopefully you can see, do you guys see that where the arteritis is? It's almost like a string sign on those vessels. And so again, they have, you know, very tight vessels. So whenever they're using their upper extremities, in this particular person's case, they're getting supply-demand imbalance. They're getting angina, or not angina, but actually the equivalent, cramps in the arm muscles, because the arm muscles are not getting enough flow. And we treat that with high-dose steroids or immunosuppressives. Let's now talk about vasospastic diseases. And vasospastic diseases, primary Raynaud syndrome is the commonest, again, in young women. And they will tell you this classic story of the color changes. And, you know, it's starting to warm up. Hopefully we'll be able to get our Weber barbecues out soon. So the color changes, my little mnemonic for that is Weber. So white is the first color change, and that's because they get the vasoconstriction. Then B for blue. So then finally the arteries start to open up, but the deoxygenated blood flows in. So it's more blue. And then finally they get the reactive hyperemia, and then the oxygenated blood comes in, which is red. So white, blue, red. They'll tell you oftentimes they'll have these classic kind of tri-color change. They may have some other signs. The main treatment for this is calcium channel blockers, biofeedback, or nitroglycerin. Now, I don't know about you guys, but you know, I've tried that. Imagine next time before this happens, or as this is happening early on, imagine you are laying down in front of your beautiful, crackling warm fireplace on your sheepskin rug, and your pussycat is purring by your tummy. And warmth, you feel warmth flowing into your extremities. Well, you know, I don't know about you guys, but I haven't had too much success with that. What I have had a lot more success with is getting them to, #1, honey-do. You go and get outside, you know, in that cold, or you go and get the stuff out of the freezer, or having them to get a pair of those 9-volt battery-charged gloves or socks that you can get on, you know, inside on the corners in New York City in the middle of winter. I've had a lot more success with those in reducing their Raynaud syndromes. Vasospastic angina. This is the oh my God ECG. The reason this is the oh my God vasospastic principal angina, because that's normally what happens in the emergency room. It's a young person often, you know, oh yeah, I'm feeling a bit of chest pain. They do the 12-lead ECG, and then everyone goes, oh my God, quick, cardiology stat, you know, and then The nurse says, okay, lay down, sir. I'm going to give you this sublingual nitroglycerin. Okay. Got a bit of a headache. How do you feel now? I feel pretty good. Then they do the ECG, and it's completely normal now. And it's like, oh my God. We have an alien amongst us. Quick, get Mulder and Scully. Let's get this worked up. Because this is not normally what happens in these patients. So the issue with, and you can see they have these huge ST, it's often all of the vessels are clamping down. And you get this widespread changes all over the place. Unfortunately, you know, the patients that we see in our hospital, many of them do have cardiovascular risk factors and stuff. And a lot of them, you know, you give them the nitro and it doesn't go away. I mean, some of them does. But oftentimes you have to just cath them at least once and get the diagnosis of the Prinzmetal's angina. We can also do provocative, where we can actually induce the spasm and see it, you know. But once we've made the diagnosis, then next time they come back to the emergency room, you know, we can just treat them and they don't have to admit them. And we, of course, use calcium channel blockers will reduce the spasm, stop the smoking. It's often brought on by smoking, and risk factor modification, like statins. Carotid artery disease, die from CAD. Repeat and augment. Carotid artery disease, die from CAD. So again, vascular disease here means vascular disease here. So we should check it out. So someone with a bruit, check out an ultrasound, or if someone's had a TIA or a stroke, check out the ultrasound of the carotid arteries. And if you can't get a good image of the carotid arteries with the ultrasound, think about doing CT or MRA. And here is an example of a high-grade stenosis, 90% of the internal carotid artery here. So how should we treat them? Again, remember, think about them as coronary artery disease, so your aspirin or clopidogrel, or you can also use aspirin and extended-release dipridamol. Get the blood pressure under control, statin them, and of course get them to stop smoking. Now, the only class 1 indication for sending someone to get fixed is this. So if they have had within the last 6 months, a TIA or a non-disabling stroke, and by ultrasound on the ipsilateral, that's ipsi same side, so on the same side that the stroke happened, they have 70% or more stenosis by ultrasound, non-invasive, or 50% by catheter angiography, then and they've had, as I said, the symptoms in the last 6 months, you should refer them to either stent or surgery. The surgery, the endarterectomy, it's great, but you remember they're under general anesthetic, there's a lot of blood loss and that, so there's higher rates of having a heart attack during that surgery. Whereas if you do a stent, you know, we go in through a catheter, they're awake, so there's less MI, less stress on the heart, but when we inflate the stent, even though we use kind of different catcher devices and things, still we have the issue of some of the plaque sometimes breaks off and goes to the brain. So they have more chance of stroke with doing the stents. And then, of course, because this is a stent, they'll need aspirin and clopidogrel, typically for 1 month. So the mantra here, guys and girls, let's just do this one. 70% non-invasive, 50% angiography, plus symptoms equals surgery. Repeat and augment. So that is the only class 1, which means the boards will probably ask you about this. So let's have a question. A patient with a TIA a month ago has had an ipsilateral internal carotid artery stenosis of 75% on ultrasound, should be referred for carotid endarterectomy or stent placement. Is that true or false? I'm feeling my 100% vibe coming on here. Okay, well, I'll take 97. So yes, the answer is yes. Remember, they had 70%. They had the symptoms within the last 6 months. They should be referred for endarterectomy or stent placement. So the answer is true, and you should not sit on them because the chance of them having another big one, just like if we sat on someone who had a problem with their coronary artery of having a big one, is increased. Okay, now, cerebral embolic disease. Let's talk about cardiac cerebral embolic disease. AFib is the most common in terms of the etiology of this. There are other causes, but AFib is the big one. So even if you get someone in, they have a a mini stroke or something like that. It's an elderly person. You might bring them in. There's normal sinus rhythm. You do heart, carotids, everything's normal. Most likely it was AFib. So make sure once they're discharged, check the Holter and maybe even consider a 30-day cardiac event recorder. That will improve the detection of AFib 5 times over the Holter. And if you don't find anything, you've got to put them on some antiplatelet. You've got to assume it is some thrombus from somewhere. Aspirin or clopidogrel or aspirin and extended release dipridamol. Okay, aortic disease. Let's talk about aortic disease. And hopefully you recognize that aortic aneurysm there from our lecture at the start of the lecture. And you've got the Ehlers-Danlos syndrome person there with their elongated face, thin nose, and the large eyes, easy bruising, including vascular problems as well, rupture of arteries, and then the Marfan syndrome. So let's talk first about thoracic aortic aneurysm. So thoracic aortic aneurysm is, any hypertension is a risk factor for any aneurysm, just as a FYI. In particular, there are some specific other ones for the thoracic aneurysm. Marfan's, Lewy-Dietz, vascular Ehlers-Danlos, bicuspid aortic valve, coarctation of the aorta, familial thoracic aortic aneurysm and dissection, and pregnancy the third trimester are independent risk factors for developing a thoracic aneurysm. So dissection. With dissection, it's, absolutely, this is kind of like the worst pain they have ever felt. I had a patient when I was at the Mass General Hospital who told me it was like, the pain it was like, they said, imagine your body is a sheet of paper or a tissue, and someone is trying to tear your body in half. They said that's what it felt like. It was literally like someone was tearing them, ripping them, trying to rip them in half. So with acute dissection, it's not like, oh yeah, I'm having a little bit of pain, this and that. It's really, really severe pain. And typically, it'll happen in the front, and then they will report it's now moving to the back. Oftentimes, they'll come in, their blood pressure's out of control as well. They may present also with syncope, with heart failure, or even a stroke. So a little trick that that may help you out is check the plasma D-dimer. Now, sometimes the boards, on the labs, click here for labs, they will actually have this in there. If the plasma D-dimer is under 500, that rules out dissection. It is not an aortic dissection. And importantly, it also rules out PE, which is something that's often on your mind with someone coming in with, severe and violent kind of onset of chest pain. So what you want to do for these individuals, if they're not in shock, you want to lower the heart rate first. So first beta blocker, then you add your vasodilator, for example, nitroprusside. And that will, if you do it in that order, that will reduce the chance of getting the reflex tachycardia. So with the type A dissection, remember that's ascending, those have to go to surgery. But with the type B now, we can actually treat them medically, which is quite nice. And, okay, so you're following your patient out in clinic with that has a thoracic aortic aneurysm. When should you refer them to surgery? If once the aneurysm gets to 5.5 centimeters in size, if it expands more than half a centimeter in 6 months, or if you're following them annually, 1 centimeter in a year, and then finally, if they have symptoms from compression of nearby structures. So the mantra here, guys and girls, greater than or equal to 5.5, greater than 0.5 and 6, symptoms, slash them. Repeat and augment. Good, okay. Now there are some slight changes in terms of the 5.5 for certain individuals. For example, Marfan's and some people with bicuspid aortic valve and valvular disease, it's a little bit less than that, but this will cover most of your patients that you are seeing for the boards. And the reason I like that is the same as the criteria for abdominal aortic aneurysm. The main difference for abdominal aortic aneurysm is the risk factors are different. It's the systemic hypertension, male smoking, emphysema, cholesterol, obesity, and genetics, mainly in 65 to 75-year-old males. Now, the good news here is that 80% of them that are 5 centimeters or over, you can actually palpate. So for your men who are 65 to 75 who have ever smoked, check that out. Check the abdomen out. And as I said before, the mantra is still the same: greater than or equal to 5.5, greater than 0.5 and 6 symptoms slash them. That's when we should refer them to surgery. And here is an example of a nice juicy aneurysm that is going to be needing surgery. Now, the good news is we have different options for surgery these days. In the old days, it was pretty big, major surgery. Nowadays, we can actually do what's called endovascular aneurysm repair, or EVAR. And it's basically the stent is acting like a sleeve. So here is the classic infrarenal, or you can do it with common iliac. So here's the aneurysm. And what we do is we essentially put in this stent, and the newer ones actually have, it's like a pair of trousers stent. It's with 2 legs. We put the stent in, and then we inflate it, and now the blood goes down the stent. And the aneurysm is basically, kind of like shut off from blood flow. So the nice thing is, it's pretty good. It works in most people, and the 30-day morbidity and mortality for EVAR is significantly lower than open surgery. But there is this thing here, the bane of the endovascular aneurysm repair folks, is this thing called endoleaks. And what this means is nature somehow finds a way. So even though we've got the stent in, somehow blood sometimes finds a way back into this aneurysm and it continues to grow. It happens in about 10%, so there is still a risk of rupture of 1%. But the good news is, in 90% of people, the aneurysm is shut off here, the blood, you get stasis, it fibrosis, clots, end of story. And of course, they'll be on dual antiplatelet therapy, and we check them for the endoleaks annually. Okay, the U.S. Preventive Services Task Force, let's talk about them. I mean, this is the most, conservative body in the United States. I mean, I'm talking, drinking port, sipping on smoking cigars, men's clubs and all the rest. And it's like, oh, but for the days of Oslo. Oh, yes. Oh, and these residents these days. Oh, yes, it's shocking. Have you seen them? I round in the morning and then someone says, I say, please tell me about the patient. Oh, but excuse me, sir, I was not, the night float admitted that patient. And so I don't really know much about that. Shocking. Oh, and the horrors of technology. Yes. Have you ever tried pimping them these days? Yes, it seems like they always have to make urgent calls on their phones and they always get it right. Oh, the horrors of technology. Well, the good old boys would like to turn back time, but that may or may not happen, but they are pretty connected, the good old boys. And so when the U.S. Preventive Services Task Force, so their normal response, anyone who says, oh, look at all these studies, isn't that a good idea? They're like, insufficient evidence. Go back and do more studies. Rejected. So their normal response is to pretty much reject everything that everyone says is a good idea. Now, once there is overwhelming evidence and they can no longer save face and reject it anymore because everyone is saying, all of the cardiology bodies, all of the internal medicine, they're all saying, look, it works, we need to do it. Then they finally do it. So one of their recent proclamations of 2005 was for abdominal aortic aneurysm screening. This is a Class 1 U.S. Preventive Services Task Force recommendation, a one-time screening for abdominal aortic aneurysm by ultrasound in men who are 65 to 75 years of age who have ever smoked. And hopefully you recognize there the smoking man from the X-Files. So hopefully he got his abdominal aortic aneurysm screening. I can tell you in my clinic, I have a cardiology clinic a couple of times every week, and at least one patient, every clinic, I have the fellow or the resident order this, and we have picked some up. So now, because the U.S. Preventive Services Task Force have said you should do this, what happens if you don't? So let's say you don't, and your patient goes and ruptures their aneurysm, and Let's say worst case they die. They will get a lawyer who's an expert in this, and they will bring a lawsuit against you, and they will bring you up and they will say, doctor, you saw this patient, you knew that they were a former smoker, he was 68, why did you not check him for abdominal aortic aneurysm? And you'll be like, really? I was supposed to do that? And they will take you to the cleaners. That's the only problem with the US Preventive Services Task Force. Once they've given it their gold stamp of approval, it is considered not only standard of care, but standard of care so high, if you don't do it, you will be fried. And I don't want any of you guys and girls getting fried, okay? Particularly by the internal medicine boards. Let's talk about infective endocarditis for a little bit. Unfortunately, us guys, it's more common. So more likely for us guys, infective endocarditis. And we have staph is the it bug for endocarditis these days. So front page of Bacterial Newsweek, staph. Front page of Bacterial Vogue, staph. Front page of Bacterial MTV, staph. Front page of, what other magazine? Rolling Stone, yeah, Rolling Stone, staph. So staph is the it bug for endocarditis. It is the #1 cause of endocarditis for native valve, Staph aureus, for prosthetic valve, coag-negative staph, like, for example, Staph epidermidis, and for cardiac implantable defibrillators and other devices, again, Staph aureus or coag-negative Staph epi, for example. So staph is the it bug. If you've got someone who comes in with infective endocarditis, get your blood cultures and then do your echo. Now, again, you know, a lot of people say, oh, should I be doing the transesophageal? No, start with the transthoracic. In fact, you will get most of them on that. Obviously, the TEE is if you suspect it and there's other signs of something going on, you know, or you're suspecting there's some complication, go for it. But always do the transthoracic first and then do your modified Duke criteria. And the modified Duke criteria include bacterial endocarditis at 5 p.m. That's my little mnemonic, because they always come in Friday night or Saturday night, 5 p.m. Just when everyone's about to go home, that's when they come in. So major criteria, bacterial, so if their blood cultures are positive for the usual guys, suspects, endocarditis, if you see evidence of endocarditis on the echo, positive echo. So that is, they're the two major. If they have the two major, Duke criteria positive. You don't have to do any further studies, you've got it. If they have all 5 minor criteria, so fever, immunologic phenomena, vascular emboli, predisposition or microbiological evidence, all 5, then they also meet criteria. And then finally, lucky number 13, if they have 1 major and 3 or more minors, they meet criteria for modified Duke. And you note that in your note, you know, positive endocarditis based on modified Duke criteria, treatment. That's it. You don't have to do any further sophisticated studies once you got the diagnosis. Just treat them. You might find some things on the physical exam. The Janeway lesions, they are flat, painless lesions of the palms and soles. Splinter hemorrhages, these are thought to be tiny little thrombi that were on the endocarditis in the heart that broke off and went either to the fingernails or to the toenails. So they're thought to be thrombotic. Let's talk about Osler's nodes just for a moment. So once I finish my work on the flux capacitor and go back in time, in the time-traveling BMW 3 Series, I'm going to head back to Hopkins and spend some time with the Big O, because, you know, he was a legend on physical exam, particularly cardiac exam, you know, named a lot of things. But then I read his biography, you know, just recently, and my gosh, I mean, rounding with the Big O. So first of all, you had to dress up full formal attire. I'm talking tails, you know, polished shoes, the rest. That was the dress code to round with the Big O. So I don't like doing that, so that would be a problem right there. Secondly, the Big O put the P in pimpology. I mean, like, he, you know, think of the worst pimper that you've ever met or you've experienced. I mean, they were nothing. I mean, the Big O was just the Terminator. I mean, he made grown men and women cry. I mean, he was just... So I was thinking, okay, I'd be back with the Big O, time traveling, we'd be on rounds, and the Big O would say, Mr. Higgins, tell me of your findings on the physical exam of this patient. And I'd be like, okay. Dr. Osler, I hear a 3/6 decrescendo murmur at the left upper radiating to the left lower sternal border. And I also see signs of a water hammer pulse peripherally, a Corrigan's sign, and pistol shot femoral pulses. And I'd be feeling pretty good about myself. And this is all consistent with moderate to severe aortic regurgitation. Mr. Higgins, very well, but would you please continue on and tell me the other 11 physical findings that you haven't yet mentioned in this patient? I'd be like, ah! So, can you imagine, guys and girls, what it would be like to round with the big O? How painful that would be? Just like Osler's nodes. Painful raised lesions on the hands and feet. Okay, Roth spots. Now in the boards, they may say, they may give you a patient with fever and positive blood cultures or something like that, and they say, as an ABIM board certified internist, you perform ophthalmoscopy like you do on all of your patients. And this is what you see. Click here. And they may show you this. Now, they may or may not have done that in the MOC that I recently did, but I cannot confirm or deny it. And then they may ask you, well, what's going on? And if you see this classic ophthalmoscopy here that shows the retinal hemorrhages with the white centers, it's red, white, and blue, very like our patriotic buddy here. Red, white, and you will be blue because your patient has endocarditis. So what about endocarditis with early surgery? There are some individuals we need to get them to the surgeons pretty quickly. So if they've gone into heart failure, that's obviously a sign. If they've got really nasty resistant organisms that are not getting better despite your antibiotics, if they've got a heart block, or they're having emboli, or you've got a prosthetic valve that's infected, again, they are not normally going to need to go to get it physically removed, unfortunately. Cardiac implantable electronic device infections. This means pacemakers, ICDs. We're putting a lot more of these in. And the mantra here, guys and girls, when infection is not in doubt, take it out. Repeat and augment. So, unfortunately, we're putting a lot more of these in. We are going to be taking a lot more of these out. So if you have someone who has an infection and it's on the lead, you do the echo and you see it on the lead, or it's in the pocket, there's an infected abscess or something in the pocket, or they have like a mitral endocarditis, for example, and they have to have a device in, or occult staph bacteremia. So you've checked all the usual places, you can't find any of it, your echo looks okay, but they're still having staph. The device has to come out. So unfortunately, you're going to be seeing more and more of that. Antibiotic prophylaxis. We used to do this on a lot of people, and the main thing for you guys to know these days is we only do it, number one, on high-risk patients, which I've listed there, prosthetic valves, previous infective endocarditis, congenital heart disease that are either unrepaired or partially repaired with shunts still present, or cardiac transplant, and only if they're going essentially for the dentist or oral surgery. So teeth, gingiva, oral mucosa. So you got to meet those two criteria now. That's it for endocarditis prophylaxis. And I just tell people to remember either the amoxicillin-based, or if they're penallergic, clindamycin, about 30 to 60 minutes before. Let's turn to the valvular disease. This is our bicuspid aortic valve ventricle singing. Push it. Because he's having to squeeze a lot harder to get the blood out of this tight bicuspid aortic valve. So the ventricle's gotten a lot more hypertrophied compared to this normal, beautiful tri-leaflet tricuspid valve. This is the most common congenital cardiac abnormality, is you're seeing here. 1% of people, so probably someone in this room has one of these or knows someone closely who has one of those. Importantly, the murmur peaks after mid-systole. So with aortic stenosis, who should we send to surgery? Those who have severe aortic stenosis, which is defined as an aortic valve area less than or equal to 1 centimeter squared. Remember, the normal aortic valve area is about 3 centimeters squared. So they've gotten very, very tight stenosis here. And we do an echo, and we show a velocity of 4 meters per second or higher, or a mean peak gradient of 40. Now, what about if they're severe aortic stenosis and they tell you that they're asymptomatic. Well, if they have an ejection fraction that's less than 50% and they have the 440, even if they're asymptomatic, they should be referred for surgery. A question comes up sometimes where you'll have someone who you're not sure, they have a very low ejection fraction. So for example, their ejection fraction might be 20% and there's not much blood going across the aortic valve. And the question is, well, is it because, the heart is not pumping much, so the valve's not opening a lot, not much blood is coming across? Or is it that they truly do have severe aortic stenosis? So the answer to that, to determining that, is you actually do a dobutamine stress echo on them. You essentially restore that 20% ejection fraction back to 60%. You actually just stimulate the muscle with dobutamine. It pumps harder. If at any time during that stress test they hit the 440, then that's true severe aortic stenosis, not pseudostenosis, and they should go to surgery. TAVR is the new kid on the block, and TAVR is shown here, and we are now using it for high or intermediate risk patients. So first thing we do is we put a balloon up and then we crack open the valve leaflets. Then we insert this special stent. And this is not just an ordinary stent. This is super stent because when we inflate the stent, inside pops open a new valve. And this is transcutaneous aortic valve replacement. Or transcatheter. It's getting a lot more popular. Acute aortic regurgitation. This again is where the blood is going back acutely the wrong way. So you should have a high index of suspicion if they have the setup for acute aortic regurgitation. And the setup for that is endocarditis, trauma. So, they might have been in a severe car accident where they got trauma to that aortic valve, or aortic dissection. And they come in basically in extremis. They have, all of a sudden, blood is going the wrong way. They come in, they're often in pulmonary edema. So what you want to do is they need urgent surgery, but in the meantime, give them dobutamine to help the heart pump more blood out, so more is going forward, and also a vasodilator as well. So again, it's easier for more blood to go forward, and less blood will go backwards. And this is an example of an endocarditis causing that problem. Chronic aortic regurgitation. So with chronic aortic regurgitation, again, any problem with the valve or aortic root, typically they'll have this increased pulse pressure. That will be the kind of tip-off. So for example, the difference between the systolic and the diastolic is very large. And they may have these peripheral findings like Waterson's water hammer pulse or Corrigan's that I was telling Dr. Osler before about. So when to do surgery on these individuals? Well, again, if they have severe aortic regurgitation, in fact, for any valve condition, most people who have a severe version of it, most of the time they're symptomatic. They might tell you oh yeah, I'm asymptomatic, but get them on a treadmill after 3 minutes, they're probably going to be huffing and puffing. So severe valve disease, most of them are going to need to be referred to surgery. For the asymptomatic severe chronic aortic regurgitation, those individuals, if they have an EF less than 50% at rest with no other cause, they should go. Also, if they have a dilated left ventricle, they should go to surgery as well. Let's now talk about mitral stenosis. So mitral stenosis, you can see here, this is a classic case of rheumatic mitral stenosis with this is the mitral valve leaflets here with this hockey stick appearance, and big left atrium and little left ventricle here. And you can see in the old days, we used to have to go in there surgically and kind of cut apart these valves, which were kind of fibrosed and stuck together. But these days, we can do it transcatheter. So still, the commonest etiology of severe mitral stenosis is acute rheumatic fever, which is in turn caused by group A beta hemolytic streptococci, so strep pyogenes. So here's the, for chronic mitral stenosis, rheumatic fever, this is not staph, this is strep. This is the commonest cause. And oftentimes they'll give you a story. They'll be from, a third world country. They will have a story of developing rheumatic fever when they're in the teens, for example, and they will show up to your office about 20 years later. That's the typical delta, commonest being mitral stenosis. And they'll tell you, they've been on aspirin, they may even still be on penicillin or erythromycin, they've been on it for years and years. So that's the etiology. Okay, so question. Acute rheumatic fever is usually caused by staph, influenza, group A, beta hemolytic strep, strep pyogenes, or Pseudomonas. Let's see how the 100%ers are working. Okay, so yes, group A, beta hemolytic strep, strep pyogenes is the commonest cause of rheumatic fever. Staph is not. Staph is a commonest cause of endocarditis. Influenza virus is not. That causes flu. And Pseudomonas is not. That causes infections in people with cystic fibrosis and hospital-acquired infections. Okay, so mitral stenosis, the physical exam for mitral stenosis. Remember, mitral stenosis, MS-DOS, the old operating system, mitral stenosis, diastolic opening snap. So that is the key physical findings with a rumble. The classic chest patient will come in with fatigue, exertional dyspnea, orthopnea, often AFib because they've got that big atrium. And the X-ray will show this lovely triad of enlarged pulmonary arteries, because remember they've got high pressure backing up onto the pulmonary system. They've got the big, large left atrium. Normally the left atrium doesn't poke out like it's doing here. And they have symptoms despite the normal sized LV, and this all points to mitral stenosis. Okay, so question time. A 37-year-old Pakistani woman presents with fatigue, exertional dyspnea, and orthopnea. She tells you she had a bad infection in her teens and has a heart murmur now. So here's her chest X-ray. So the question is, what does she have? Pulmonary embolism, atrial myxoma, aortic aneurysm, and mitral stenosis. So 37, had a bad infection in her teens, got a heart murmur now. Okay, so most of you guys are on the money. So she is a classic mitral stenosis with acute rheumatic fever history. She doesn't have a PE. I mean, this was dyspnea on exertion, and this was a chronic thing, and also does not have the physical findings of that. Atrial myxoma, no, this would not be consistent with someone who had an infection in their teens and now is presenting to you 30 years later. So that is incorrect. Chronic severe mitral stenosis. So with chronic severe mitral stenosis, these individuals, the definition of severe mitral stenosis now is a mitral valve area less than or equal to 1.5 centimeters squared. And the good news is, if it's someone, particularly if it's with rheumatic mitral stenosis and they're younger, as long as they don't have any left atrial thrombus or they don't have moderate to severe mitral regurgitation, and they have a Wilkins score of less than or equal to 8, which is a special echo score we use. Again, the higher the score, the more calcium and the more deformities of the leaflets, then they can actually go for percutaneous mitral balloon commissurotomy, which is kind of cool, which you can see it here. They go in with a catheter, put the catheter across the stenosed mitral valve, and then they inflate a balloon and essentially crack the leaflets apart. And it works really, really good in most people, and most people only need it once. If they are not candidates for that, then obviously you need to repair them. We prefer repair if possible, or do a mitral valve replacement. Acute mitral regurgitation. Well, acute mitral regurgitation, again, just like acute aortic regurgitation, it may be related to endocarditis, trauma, but a commonest cause actually is these individuals that have myxomatous chordae, which are these really thick cords and associated with mitral valve prolapse, and they tear, and this is the commonest cause of acute mitral regurgitation. And they will present with shock. Again, all of a sudden, everything's going the right way, and then all of a sudden now everything's going backward, the wrong way. So they present in extremis, shock. You want to, again, help the heart to pump more blood forward and vasodilate them, so more blood goes forward and less goes backward. And importantly, bless you, you also put in one of these. This is an intra-aortic balloon pump. This will help, by its suction and other mechanisms, pull more blood out and forward into the heart while we get them to the OR. Again, acute AR and acute MR need to go urgently to surgery. Chronic mitral regurgitation. Well, in this, here's a echo showing here's the left ventricle contracting, and you can see all of this blood going back into the left atrium abnormally. So a picture is worth 14 words, so it can be a problem. Anything from the mitral annulus to the leaflets to the chordae to the papillary muscles to the left ventricle, or a combination of any of those can result in chronic mitral regurgitation over time. So the 30-40 rule with chronic mitral regurgitation, when should we send someone to surgery? First of all, again, if they're really symptomatic and as long as their ejection fraction is still over 30. If you've waited too long and their LV's failed and now it's less than 30, oftentimes people will not take them to the OR because they can't get them off the heart-lung machine. What about asymptomatic patients? So an asymptomatic patient with severe mitral regurgitation, as long as their ejection fraction is 30 to 60%, and this is where the 30-40 rule comes in. If you look at their left ventricular end systolic dimension, so what is that? So remember, systole is contraction and diastole is relaxation. So normally, the left ventricle, when it contracts really good. It normally contracts down to, 20 or 2 centimeters. If the left ventricle starts to fail, it can't contract in as much. And so at the end of systole, it's now, if it's 4 centimeters or 40 millimeters or more, then that is really severe damage. And you want to get that person, even if they're asymptomatic, to the OR. So remember that number. That may come up in a question soon. We prefer mitral valve repair, if we can, to replacement. Some of your institutions, including ours, are doing the MitraClip now. So if someone's a really high risk for surgery and they won't be taken, here is someone with severe mitral regurg. You can see the severe jets. They basically put this little clip. It's almost like kind of a super paper clip over, and they clip it on the valve, and then they reduce the regurgitation. So that is a possibility for some individuals. Okay, question 18. A 51-year-old man presents with a murmur. He's inactive, has a desk job, and uses the elevator. He denies symptoms, but reports he doesn't exercise. He's a bachelor and watches movies and drinks beer on the weekends. So his physical findings, the main thing is he's got this 4/6 systolic murmur, loudest at the apex. You do the echo, his EF is 45%, and he has a left ventricular end systolic dimension of 4.8 centimeters. That is abnormally large. So the question is, what do you want to do for this patient? Do you want to start him on lisinopril? Do you want to refer for mitral valve repair replacement? Start nifedipine, follow in clinic closely, or refer for percutaneous balloon commissurotomy? Okay, good job. You guys are on it. So refer for mitral valve replacement repair. This guy's got a dilated left ventricle. He's already started to fail. You don't want to wait. So that's why C is not correct. You don't want to wait. You need to send him now. Otherwise, his EF will continue to fall and he may not be a candidate. Prosthetic heart valves. Let's talk about that. The younger people under 50, we want to give this mechanical, like a St. Jude or something, because that will last a lot longer as long as they can take anticoagulation. For the older people over 70, we generally go with a bioprosthesis because we know that oftentimes those individuals will have problems with anticoagulation. And then in between, depending on patient factors. The main thing that I want you guys to take away from the new guidelines is for antithrombotic therapy. It is now dual therapy. That is Coumadin and aspirin. So Coumadin and aspirin, baby aspirin, on everyone who has a mechanical valve. That is the new guidelines. Okay, question. A 60-year-old woman just underwent valvular surgery. Mechanical valve was placed in the mitral position. She's otherwise healthy, does not take any medicines. You hear a nice crisp mechanical S1, normal S2 with no murmurs. So what antithrombotic medication should she take? Okay, good. Okay, most of you got it. So she should be on now. She's a mechanical. The new guidelines, warfarin and aspirin is correct. Clopidogrel and aspirin is not correct. That's actually not indicated. And so she should be on warfarin and aspirin. What about surgery with these individuals? Occasionally, we do have to take them to surgery if they are having a minor procedure. If you could just continue everything. If it's something minor, If it's more major, we stop it for 5 days. If it's an aortic valve, we just let them drift down. But if it's mitral, we generally do bridging. But the good news is we can use subcutaneous low molecular weight heparin as well. Sometimes they might get thrombosed, so do usual testing for thrombosis. We fibrinolyze them, and bioprosthetics, you can just start them back on Coumadin. There are some other options as well, but when in doubt, consult it out. Lecture 4, we're going to be talking about some of the arrhythmias as well as heart failure and tamponade. So let's start with the arrhythmias. So just a couple of general principles. Most of the arrhythmias are going to be re-entrant, back or again, enter. So they're kind of like a cyclical type thing, whether it be in the atria, the ventricles, or in the AV node. Narrow complex generally are going to be supraventricular. Holter monitor is where we normally start with most people, and then we can move on to other tests as needed. In the supraventricular system, the people are represented by 2 separate yet equally important arrhythmias: atrial flutter, which is regular, and atrial fibrillation, which is highly irregular. These are the stories. Boom, boom. So, atrial flutter. This is going to be you can see the flutter waves represented on the ECG here. Typically, the atrial rate is going to be around 300, and the ventricular rate is going to be lower than that. And so classically, you will see the sawtooth pattern in those inferior leads. The classic one is the type 1 or the cavo-tricuspid isthmus dependent. Essentially, you've got this counterclockwise circuit running between the inferior vena cava and the tricuspid valve, going around about 3 times per second. Treatment nowadays, we treat AFib and A-flutter basically the same. Again, if they're acutely unstable, you want to cardiovert them. And if they're not, then you can use medications. The good news with flutter is that catheter ablation has a 95% success. So, typically with flutter, first-time flutters, we'll just cardiovert them and get them back. But if they come back in, and especially if they're symptomatic, despite, the medicines we've got them on, then send them for catheter ablation. As I said, 95% success. Oh, question 20. A 76-year-old female was diagnosed a month ago with atrial flutter and underwent cardioversion to normal sinus rhythm. She now reports palpitations have returned, is fatigued and unable to exercise. She doesn't like it. ECG today shows recurrent atrial flutter. Ventricular rate 71. She's got high blood pressure, heart failure, preserved EF, diabetes. She's on apixaban, metoprolol, lisinopril, metformin, and rosuvastatin. So despite, having a good ventricular rate control, she's really, really symptomatic. You check her, she's got an irregular pulse. You've got a echo post-cardioversion, showed EF 55%, left atrial dilatation, diastolic dysfunction. Nuclear stress shows normal perfusion in EF. So the question is, she's got this recurrence of atrial flutter, what would you like to do now? Do you want to cardiovert her, send her for catheter ablation, or do nothing? And she seems to be very symptomatic despite the medicines you've got her on. Excellent. Most of you guys got the right answer. Yes, the boards say basically if you've already tried once and she's back into it, more than likely if you cardiovert her again, she's going to be back, next month, same thing. So that's why B is no longer indicated here. Catheterization, there's no indication for catheterization in this person, and she had a normal nuclear stress test. So you want to refer her for a flutter ablation. Again, 95% successful in this population. Atrial fibrillation. So atrial fibrillation is similar to flutter in that there are little circuits, but there are multiple little circuits all over the atrium. And they have, you can see here on the ECG, often it's kind of in a regular baseline, and sometimes you can see these waves here, we call them F waves, because they're totally effed up. Actually, we call them that, they're fibrillatory waves. And literally, these are these little tiny circuits going around and around, causing these different little fibrillatory waves. So this is classic atrial fibrillation. We have different names for it, depending on how long it is around. Paroxysmal under 7 days, persistent over 7 days, long-standing persistent more than a year. Permanent is basically continuous. And importantly, because most AFib is related to mitral valvular disease and left atrial issues, then these are mostly caused by that. However, there is this subgroup non-valvular. So you have no mitral issues, no mitral valve disease, or mitral valve repair. So for rate control, there's two things for AFib, rate control and anticoagulation. For rate control, per the new guidelines, strict rate control is considered 80 beats per minute on average at rest, or 110 during a 6-minute walk. So you want to get those people, when you're in hospital, try to get them down to a resting heart rate of under 80. Now, if let's say they really want to go home, they said, I'm going home today, doc, no matter what, and let's say their heart rate is 90, as long as they have an ejection fraction over 40 or higher, and they're not symptomatic and they can walk around okay, it's reasonable to send them home for that. So acute atrial fibrillation, we want to control them with beta blockers intravenously or calcium channel blockers, and DIG and amiodarone. For chronic AFib, again, the same medications, but on an oral basis. If they have heart failure, we particularly like metoprolol succinate and carvedilol, as well as calcium channel blockers. And if they have heart failure, reduced ejection fraction, other options to the beta blockers include dofetilide, digoxin, and amiodarone. And then finally, if they're unstable AFib or any SVT for that matter, then we want to blast them. So if they're having chest pain because of the AFib with RVR, or if they're hypotense or heart failure, despite what you're doing, you need to urgently synchronize cardioversion them. So let's have a look at this question. A 25-year-old female soccer player comes to the emergency department. She reported having palpitations and nearly passed out at soccer training 15 minutes ago. Her blood pressure is 70/40. So here is her ECG. And the question is, and her blood pressure is 70/40, what would you like to do now? Do you want to give her IV diltiazem, IV esmolol, synchronized cardioversion, or IV digoxin? And your ECG should be in your book as well if you need to take another look. Okay, so you guys, most of you guys are on the money. So she is hemodynamically unstable AFib. She's 70/50. She's got a very fast rate. You need to cardiovert her in the emergency room. IV DILT and esmol are contraindicated because her blood pressure is she's already hypotense, and IV digoxin will not do anything for this fast heart rate. Remember, with DIG, you always have to use it with a beta blocker or calcium channel blocker, which again are contraindicated in this situation. Amiodarone. Now, amiodarone is a good drug, and my med students particularly like this. You know, I tell them, okay, when your attending asks you what are the contraindications to amiodarone, just look them straight back in the eye and just say, what a bitch. Shock and awe, that's what I tell them. Now, the attending will be like, oh my God, I've got a psychotic med student on my team this month. What am I going to do? And while they're kind of thinking about that and they're kind of lost focus, then you can say, you know, B for bradycardia, B for blue man syndrome. Don't forget the sunscreen. I, interstitial lung disease. I for increased QTC interval. T for thyroid, hypothyroid being more common. T for tremor. C for corneal microdeposits. And cytochrome P450 inhibition, which means you have to drop the doses of some medications. And then finally, H for hepatic and hypotense, especially with IV amiodarone. Rate control versus actually rhythm control. Well, the studies are in, starting with AFFIRM and other studies, no difference, amazingly, in most people. However, there is a small subgroup of people that are very, very symptomatic. They know exactly the second they went into atrial fibrillation, and they hate it. They can't do anything. You know, they can't sleep because they're hearing the blah, 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 blah in their ear. They can't do it, you know, they can't work. They can't sit, they can't concentrate. And so these individuals, we try to get them back into normal sinus rhythm. We cardiovert them either electrically or chemically, and then we try to maintain them with either a class 1 agent or a class 3 agent. Now, if you're not sure what, you don't have the echo back, you're not sure what their structural heart disease, a good med to use as a first line is amiodarone in this situation until you get information back. Anticoagulation. So this is the other part of AFib. There are 3 different categories for anticoagulation. The first is lone AFib. So this is literally they have atrial fibrillation by themselves, nothing else. And in these individuals, you don't have to do anything if you don't want to, or you can do aspirin, just a baby aspirin. If they have valvular atrial fibrillation, they need to have Coumadin. And that also includes anyone who has hypertrophic cardiomyopathy as well, or a valve. And then finally, if they have non-valvular AFib, this is when we use the CHADS-2 VASC score to figure out what to do. And here is the CHADS-2 VASC score. Here, CHF, any history, or LVEF less than 40%, hypertension, age greater than 75, 2. Diabetes, stroke, TIA or thrombolism, 2. Vascular disease, age 65 to 74, 1, and sex category female, 1. If they have a CHADS-2 VASC of 0, nothing. 1, aspirin, or nothing. And then 2 or higher, that's when you have to do warfarin or your NOACs. Or if they are really, really high risk of bleeding, you can consider a left atrial occluding device, like the Watchman. So for these, you can check out the HAS-bleed score. If the HAS-bleed score is 3 or higher, have some caution. But honestly, what most of us do, because let me tell you, if someone has a big stroke, it's a big, there's some studies, 50% mortality within 1 year after they've had a big stroke, especially if they're bedbound. So what I normally do is I put them on the NOAC or the DOAC, and if they do have, a fall, or if they do have a GI bleed, most of the time they come into hospital, they have to get a bit of blood or something, then I will just put them on aspirin or something like that. And of course, have a discussion with them. But remember, stroke, the best way to reduce stroke is Coumadin or the NOACs, DOACs. So the dabigatran or Pradaxa is probably the first line agent for a lot of people. D for dabigatran, D for direct thrombin inhibitor. And this is indicated for anyone who is a CHADS-2 VASC of 2 or higher with AFib or A-flutter, and they either cannot take Coumadin or they refuse to take Coumadin. And the standard dose is 150 milligrams BID. If they have reduced renal function, we have that dose. We can't use it if they have really severe renal function or they're on dialysis. The other agents that are on that list, rivaroxaban, apixaban, and edoxaban. So my little mnemonic here is RAFE. So Rivarox, Apix, Edox, they are the factor 10A inhibitors. And the one I would point out to differentiate here is apixaban or Eliquis. A for apixaban, A for age greater than or equal to 75 or high risk for anemia, so bleeding, or acting up kidneys. So this is the only one that is indicated for individuals that are on dialysis or have complete loss of kidney function. Apixaban. It's been found to be better in elderly individuals, and it's the only one that actually has a lower or similar risk of GI bleeding to Coumadin. All the other DOACs have higher risk for GI bleeding than Coumadin, but this one doesn't. Okay, question 22. A 67-year-old African-American female patient with permanent atrial fibrillation comes in. She's taking metoprolol succinate for rate control and lisinopril for hypertension and metformin for type 2 diabetes. Her labs are normal, including normal renal function. She refuses to take Coumadin. What do you recommend now for her anticoagulation? So hopefully you've done a little CHADS-2 VASC score there. Do you want aspirin and combo, aspirin, regular aspirin, dabigatran 150, dabigatran 75, and clopidogrel 75? What would you like in her case? Is our 100% going to appear here? Wow, okay, good. Most of you guys are on the money. So she is a CHADS-2 VASC of what? Yeah, it's over 2. So she needs to be on a DOAC or Coumadin. So the only DOAC or Coumadin here are C and D, and she has normal renal function, so she gets the normal dose, 150 milligrams BID. Aspirin and dipridamol. No, that's not indicated. That is indicated for certain peripheral arterial disease and carotid disease, so that's wrong. Aspirin, wrong. That's only indicated if the CHADS2 VASC is 0 or 1. And clopidogrel, again, not indicated. No one got that. Great. So preventing thromboembolism in our individuals. So if someone comes in with AFib and aflutter, and it's been more than 48 hours, typically what we'll do is we'll start them on some anticoagulation and then get them back, cardiovert them after 3 weeks, and then keep them on that for 4 weeks. Let's say that someone is hemodynamically unstable and they come in and we need to cardiovert them right then and there. Well, we cardiovert them because they're hemodynamically unstable. Then we put them on Coumadin or a NOAC for at least 4 weeks after the cardioversion, and then check, if they're maintained sinus rhythm. If they are AFib flutter, but let's say they have a really high risk of stroke, and you want to cardiovert them, but you want them on some sort of protection while you cardiovert them, well, you can either do IV heparin, low molecular weight heparin, or directed thrombin inhibitor or factor 10A inhibitor, do your cardioversion, and then per the CHADS2 VASC. Now, this is something that you do need to know. The boards like to ask you about this. That is, people with coronary artery disease that also have AFib. What do we do? So if they've had a recent ACS and a stent, that is, in the last year, and they have AFib, we have them on their dual antiplatelet, so aspirin, clopidogrel, and per the CHADS2 VASC. So that would be Coumadin, for example, or dabigatran. So they will be on triple therapy. If they have been stable with their coronary artery disease more than 12 months, so let's say they had a stent 3 years ago, and now, and let's say they're on aspirin and clopidogrel when they come in to see you, because a lot of people do take dual antiplatelet now chronically. So let's say they're on that, and now they're AFib. So what do you do? But the CAD is completely stable. You actually stop the aspirin, clopidogrel, and then you start oral anticoagulation, either Coumadin or the DOAC. So this is something you need to know. This is in the new guidelines, and like I said, the boards may ask you, and I may ask you about it too. What about surgery? And they're on a NOAC or DOAC. What do you do with that? If it's minor surgery, like a colonoscopy, and they might be getting a biopsy, just stop it 1 day before. If it's more major, biopsy or spinal surgery, then stop it 2 days before their surgery. Okay, question 23. A 77-year-old woman is seen in for routine follow-up. She's been chest pain-free, feels pretty good. She had a stent 3 years ago. Again, is feeling great, no chest pain. Meds include aspirin, metoprolol, succinate, ramipril, and atorvastatin. Her vital signs are normal. However, she's got an irregular heart sounds. And you do an ECG, it shows AFib. Average ventricular rate of 72 beats per minute. She's asymptomatic with that. Which of the following is the most appropriate treatment for this patient now? Add oral anticoagulation, add clopidogrel and oral anticoagulation, add clopidogrel, or stop aspirin and begin oral anticoagulation. Okay, good. Most of you guys are on the money here. Again, this is it's sort of tricky. Again, she's got stable coronary disease. So the guidelines actually say if she's now AFib, you can stop anything she's on for coronary disease, the aspirin and the clopidogrel, and then start her on oral anticoagulation, which is the correct answer, D. Now, adding clopidogrel, again, that is not indicated per the guidelines. Adding clopidogrel and oral anticoagulation, the reason we don't do all of this is that actually when you're on triple therapy, there is a significant increase in bleeding, including intracranial bleeding. And then finally, adding oral anticoagulation, again, increasing bleeding. So remember, you stop any of the DAPT, which includes aspirin or clopidogrel, and just begin oral anticoagulation. Occasionally we get, as I said, we get some people who are really, really symptomatic. These are the paroxysmal people, they know exactly when they come into it, they come in, they get cardioverted. So if they have had this happen time and time again, and you've tried either a class 1 or a class 3 agent, and they still are having the paroxysmal atrial fibrillation, in other words, they failed that, you can do what's called pulmonary vein isolation. So remember there are 4 pulmonary veins that enter into the left atrium. They're the only veins in the body that carry oxygenated blood back from the lungs to the left atrium. So what they found is a lot of paroxysmal atrial fibrillation starts, actually, the little circuits start in the veins and then kind of spread down into the left atrium. So what they've done is they make almost like a fire break. They go in with a catheter and they kind of like burn or freeze around each of the bases of the pulmonary veins. So when the little wavelets start in the pulmonary veins and they move down toward the left atrium, they get to these fire breaks and it's like they burn out. They don't go into the left atrium. It's very successful. It's only indicated, however, paroxysmal atrial fibrillation, not for permanent. It's only for paroxysmal that is refractory or intolerant to at least one of the maintenance drugs. And importantly too, they also have to have at least 2 months after the procedure of anticoagulation. So they have to be able to take Coumadin or a DOAC or NOAC as well. So if they can't take those, they can't be referred for pulmonary vein ablation. The other type of ablation that we do is for those people that are in AFib and the heart rate is all over the place and we cannot control them no matter what we do. You know, sometimes they're too low and they're dizzy, sometimes they're too high and they're dizzy, and we've tried all sorts of medications and we just can't get them into the right rate control. And I'm sure you've all had patients like that. That's when we generally will kind of bite the bullet. We will go in and just take out the AV node and put a catheter, a pacemaker in so that we can control the lower rate. Set it at 60 so it will not go lower than 60, for example, and then put them on some medicine to control the rate higher. It works very well, improves exercise tolerance, ejection fraction, and quality of life. They still obviously need to be on anticoagulation because many of them, even if they're in sinus rhythm at the time, many of them go back in and out of AFib. Couple of special groups, whip it good. So if you've got Wolff-Parkinson-White syndrome and hemodynamically stable AFib, so these are the people that come in and they do kind of freak you out a bit because they're in AFib, but they're not in normal AFib, you know, with a heart rate of 180. They are in AFib and they're going at like 300. They typically tend to be younger people. And sometimes you know that they've got the Wolff, sometimes you don't. You may see kind of a wide complexes or whatever. For those individuals, importantly, because they are conducting, the reason they're going so fast is they're using that accessory pathway. You don't want to do anything to affect the AV node, the normal pathway. You want to do everything so the normal pathway can take over because that will slow them down. So for those individuals, the drugs of choice are the whipperates. So iobutylide, procainamide, or amiodarone. Those are the class 1 for someone with hemodynamically stable AFib with Wolff-Parkinson-White really fast. If they, like our lady that came in earlier from soccer practice, if she's hemodynamically significant, you know, very low blood pressure, obviously we cardiovert them. Thyrotoxicosis related or post-op, we can use beta blockers or non-dihydropyridine calcium channel blockers, as well as amio. And in fact, amio and beta blockers have been shown and are sometimes used in people that are going for cardiac surgery where there's a really high rate of post-op AFib. They've been shown to reduce AFib. Inappropriate sinus tachycardia or IST. So this is a fascinating thing. To me, it's very interesting. It's where someone with a resting heart rate over 100, an average of greater than 90 on a 24-hour Holter. Interestingly, it's the most common in women in their 20s to 40s who are healthcare professionals. It's very, very interesting. And all of the other things have been excluded. So you've excluded thyroid, anemia, pheo, dehydration, pain, etc. And they're really symptomatic. So if they fall into that criteria, we do have a new medicine, the ivabradine. It actually slows, the nice thing is it slows the heart rate without affecting blood pressure. And the reason this is good, that we have this new medicine, is that traditional beta blockers and calcium channel blockers just make these people feel terrible. They may slow their rate down a bit, but they actually feel worse than when they were not on them. Ventricular arrhythmias. Let's talk about ventricular arrhythmias now. So the commonest ventricular arrhythmia that you probably see is just plain old premature ventricular complexes, or PVCs, also known as ventricular extrasystoles. So they have a wide abnormal QRS, a compensatory pause, and do you know that 75% of healthy persons have rare PVCs? So most of you have had them, And you sometimes you'll feel it if you're really sleep deprived, or you're hypercaffeinated because you've been on call last night and you're trying to stay awake, or sometimes you might have done a really big, extended exercise session, and you just kind of feel like almost like a bit of a thump in your chest. Well, that thump is the beat after the PVC, because the PVC came early, it emptied the little bit of blood that was in your heart, but now, because there's less blood came out, the heart fills up extra big, and then the next beat after the PVC is extra big. And you sometimes feel that as kind of a little bit of a thump in your chest. If there's a lot of PVCs or they're really frequent, we sometimes will treat them, try to reduce them with beta blockers or non-dihydropyridine calcium channel blockers. But most people it's just situational, and you just need to, get better sleep, cut back on your caffeine or whatever. Okay, question 24. A 26-year-old male complains of occasional palpitations. He runs 18 miles a week, no symptoms. He drinks 8 cups of coffee and a 24-ounce energy drink daily. So here is this ECG strip you do in the office. So what would you like to do for this guy now? Do you want put an ICD in, reassure and cut back on the caffeine, amio him, or let's just blast him in the office right now? Let's defibrillate him. Okay, so yes, a common stimulator of PVCs is caffeine. So he's taken too much, definitely too much, so we want to reassure and cut back. Amiodarone, no. Again, as I mentioned before, PVCs, simple unifocal PVCs are very common. This guy has no cardiopulmonary disease. Anyone that is running 18 miles a week like that and is not having any symptoms when he's running, they don't have cardiopulmonary disease. Now, non-sustained ventricular tachycardia is shown here. The simplest definition, 3 or more sequential PVCs at a rate more than 100 beats per minute. So if you saw this on someone who was having an exercise test, this is when we would stop the exercise test. So this is what we call non-sustained ventricular tachycardia, as opposed to this one, which is sustained ventricular tachycardia. And hopefully you can see those PVCs, they're going through, and the arrows I'm showing you there are the atrial beats here. So they're the P waves. You can see the P waves and the QRS complexes are not talking to each other at all. They're not communicating. Just like Chris and Gwyneth. They're just doing their own thing and are, they're happy, but they're not communicating, just like these atria and the ventricles. So ventricular tachycardia is important to diagnose. Most wide complex tachycardias that you're going to see, if you just guess that they're ventricular tachycardia, you're going to be right most of the time. The wider and the nastier they look, the more likely it's going to be VT. If you see one of these, this is called a capture or a Dresler's beat. So remember here, the ventricles are just depolarizing everything. The PVCs, they've got something going on in the ventricles. So every time the P wave, fires and goes down to the AB node is refractory. But if you get a perfectly timed P wave coming down, hitting the AB node at a perfect timing, when the ventricle, for that few milliseconds where it's actually not refractory, it can go down and cause a normal beat. And this is what's called a capture or Dresler's beat, and this seals the deal. Managing VT, you want to, if they're unstable, obviously, like any unstable arrhythmia, cardiovert them. If they're stable, see if you can find out what's driving the VT and then amio them, or metoprolol if you are thinking of RVOT, ventricular tachycardia. Ventricular fibrillation. So this is chaos. So as opposed to, atrial fibrillation. So in the case of atrial fibrillation, remember we said there were lots of those little circuits going around. The atria are doing this, but the ventricles, so the human ECG, atria, hands, and ventricles are my legs. So the atria are doing this, and then the ventricles are still contracting and pushing out most of that blood, okay? Despite what the atria are doing. So, most people are going to be okay. But in ventricular fibrillation, in this case, you've got the ventricles going like this. And, I'm sorry, Taylor, but they cannot shake it off. And you are not going to be able to shake it off, and you are going to go down because if there's not enough blood coming out of those ventricles because they're shaken, then not enough perfusion of the brain, it's time, crash, burn. No discernible P waves, you can see here, and it's sort of like something from outer space there. Let's now talk about pacemakers and when someone needs a pacemaker. Here are the permanent pacing indications, updated. Symptomatic bradycardia. Now, this also includes if someone requires a medicine for their therapy and it is causing them to be bradycardic, that is also, and you can't stop it because they really need it, that is also indicated. Sinus node dysfunction, sinus pauses, chronotropic incompetence. So if you want to define that subjectively, that is, you get them on a treadmill, and if they can't get to 80% of their maximum predicted heart rate. So that's essentially most symptomatic bradycardia or symptomatic second or third degree heart block or symptomatic AFib need a pacemaker. Or someone with syncope with certain findings on a EP study. Now the asymptomatic patients, if they're asymptomatic but they have a significant advanced second degree or third degree AV block, or they have this baby down the bottom here, which is called an asymptomatic alternating bifascicular bundle branch block. So here you've got, this is lead V1, left bundle branch block. Right bundle, right bundle, right bundle, left bundle. This person is a very short time away from going into complete heart block. And this is also indicated even if they're asymptomatic. Okay, syncope. Let's talk about syncope. And, just wanted to talk about, it's kind of funny, the comparison syncope, back in the day. So back, let's say around the turn of the century, you're at at a formal party, everyone's sipping French champagne or wine, and, you feel like, you're going to pass out. And, of course, how embarrassing, for a gentleman or a woman to pass out, in front of company. So, you feel like, gee, I think I'm going to pass out. I better scoot away from the party and go to one of the rooms outside. And so, okay, all right, I'm okay. All right, get back. I don't know what caused that, but okay, I'm feeling better now. Okay. So that was back in the day, but these days, now with syncope, it's like, okay, dude, let's have some more Jägermeister shots. Okay, where are we? Dude, I'm going to pass out quick. Shh, okay. And then it's like, oh, wow, look how many likes I got. Oh, I got to do it again. I mentioned that in a little bit of tongue-in-cheek. Believe it or not, we are getting patients sending us videos now of different things, seizures, syncopes and stuff. You may have had that too, but this area of medicine is coming in. It's you will see it in the future. That is medicine via smartphone. It is coming in. We're getting it with ECGs and things as well. But anyway, syncope is changing a bit, but the things that have not changed are what causes syncope right now. Now, syncope, just so we're all on the same page, what is syncope? So it is one of those prehistoric kind of things that your body does. So it's like almost like in your DNA. It's like with babies when you drop them back for 6 months, the Moro reflex. It is a deep down reflex. And so here's what happens with syncope. Your brain normally likes to have a very clearly defined flow and blood pressure of blood in a very, very short window. So it's like goes like this. If it goes like down a bit, then the brain kind of releases a little bit more adrenaline from, and it really tightens up your vascular tone a little bit, so it goes back up. If it goes too high, it vasodilates a little bit. So it likes to have this, it auto-regulates very, very tightly. So if the brain does that, and let's say the blood pressure falls all of a sudden, and it's going like this, and the brain does this little auto-regulation, and nothing